So in chapter 17, we're going to look at control of cardiovascular function, just as a nice kind of summary of that. So we're going to start out here with a scenario where we talk about how if we inject a patient with medication in their arm, within a few minutes, some of that drug has already reached the liver, and so it's already being deactivated. So the question here says, what path did that drug take to get to the liver? You know, it didn't go straight from the arm to the liver. So to summarize that, we can look at basically just circulation throughout the body in a really simplistic form, but then kind of tie it back to our previous question there. So if you look at the heart, remember the heart functions as a muscular pump, and it's made of cardiac muscle. So we say that it's actually involuntary and autorhythmic. So it's always going to be beating at some point. And what we find then is that there's two major sides to the heart. We have the right side and the left side. The right side of the heart receives blood from the rest of the body. And you can see that that blood is blue here, or at least depicted as blue. It wouldn't really be blue in the body, but we're showing it as being blue here because it's representing that it's deoxygenated or has low oxygen. So what happens is the right side of the heart, like the right atrium, is going to receive blood from the head and upper limbs, from the superior vena cava, and then from the rest of your body via the inferior vena cava. And those vena cava drain into the right atrium. The right atrium contracts blood into the right ventricle, where the right ventricle effectively forces blood out through the pulmonary trunk, down through the pulmonary arteries, out towards the lungs. So what we talk about then is that the right side of the heart is part of what we call the pulmonary circuit. And the pulmonary circuit refers to the fact that your right side of the heart, well, it receives blood from the body, but it pumps blood towards the lungs. That's why we call it the pulmonary circuit. Then what happens is that blood, once it's oxygenated in the lungs and forced along, it gets forced back towards the left side of the heart via the pulmonary veins. And that's why it's showing as being red here, is that's representing oxygenated blood at this point. And then the pulmonary veins drain into the left atrium. Left atrium contracts and forces blood into the left ventricle. And then the left ventricle effectively forces blood out through the aorta, out to the rest of the body. So it's at this point then that you get branching of arteries off of the aorta. Some of these go to like the head and upper limbs, and some of these actually continue down towards your digestive tract, kidneys, and your lower limbs as well. Now, if you follow the circulation, you'll find then that at the distal tissues here, they're basically using that oxygen, and then blood returns back towards the heart in its more deoxygenated state. Now, to be deoxygenated is more of a misnomer because your blood's never going to be fully deoxygenated. It's just going to have a little bit less oxygen than maximal levels. But when that blood returns back towards the heart, then the right side of your heart pumps that blood back towards the lungs again. So what we find then is that your heart, as a muscular pump, contributes to two different circulations. The right side of the heart contributes to the pulmonary circulation. The left side of the heart contributes to systemic circulation, which is everything else. But they're interlinked, right? Because the left side of the heart would need blood from the right side of the heart, and vice versa. Like the right side of the heart's only going to receive blood if the left side of the heart's actually moving that along. So although they function independently of each other, they're also very intimately linked. And we'll talk about how that relates with heart failure. So true or false? The pulmonary circulation moves blood through the left side of the heart. Well, we know that that's false, right? Because it's actually the systemic circulation that moves blood from the left side of the heart out to the rest of the body. It's the right side of the heart that pumps blood towards the lungs and then via the pulmonary arteries, and the left side of the heart basically pumps that blood out to the rest of your body's tissues, which is considered part of the systemic circulation. So the reason why this is important to consider is that when we go to talk about heart failure, we'll say that, okay, if you have left-sided heart failure, we would know then that your systemic circuit, like all of your distal tissues, would get less blood flow because that's the left side of the heart. It's not pumping enough blood out to those areas. And same with the right side of the heart, right? If the right side of the heart can't pump blood to the lungs, then that blood's going to back up into the systemic veins, like the jugular veins and your vena cava, and those actually start to get larger, and that's one of the ways that we can actually diagnose right-sided heart failure. But we'll come back to that in a future chapter. So in order to talk about how the heart works and how that relates to blood vessels, we got to kind of define some different terms here, right? So fluid flow through a vessel depends on a couple different factors here. First of all, it depends on pressure differential. Like fluid only moves from high pressure to low pressure. We call that delta P. So the function of the heart then is to maintain this pressure differential, where the highest blood pressure is going to be at the level of the left ventricle. That's going to force that blood and compress it. It's going to generate a lot of pressure in a local area. Then the tendency of that blood then is going to want to move to an area of lower pressure, which ends up being in the periphery. And that's what really generates the flow here. So we need a pressure differential in order to keep fluid moving. And so pressure is also significant because it keeps your vessels from collapsing. Now, resistance of the vessels also helps determine pressure because they are proportional. If you increase resistance, then you're going to increase pressure. Now, what we find then is that if the vessel's resistance increases, like if it's more resistant to flow, we'll say then that pressure is higher there. And so smaller vessels have more resistance, longer vessels also have more resistance, and if your blood's more viscous, there's more resistance. And the same goes for the opposite of these, right? Larger vessels have less resistance, shorter vessels have less resistance, and blood that's less viscous, a little bit more watery and more fluid, is going to have even less resistance. Now, these are important to consider when we start thinking about things like pressure and flow. So although pressure is proportional to resistance, we'll find, though, that flow is inversely proportional to resistance. So your blood's going to flow even faster if your resistance is lower. So your blood flow really depends on, first of all, your heart creating that pressure differential. We talked about how blood only flows from high to low pressure. So you need a pressure difference for blood to flow, and blood will always move from high to low pressure. So your heart keeps pushing that blood through, and it's going to help generate that pressure differential. Now, blood pressure declines over the course of your blood vessels because you start to lose energy through friction. Blood pressure is going to maintain, vessel patency so that, they can flow very well. Now, if a vessel's resistance to fluid flow increases, this can occur during constriction, and you can actually get increased resistance if you have more hematocrit. So if vessels vasoconstrict, like if you make the vessel more narrow, that's going to increase resistance, which also increases pressure. Because remember, pressure and resistance are proportional here. But that's also going to decrease flow because flow is inversely proportional to resistance. If you increase resistance, you're actually going to decrease flow. And if you decrease resistance, you're going to increase blood flow. So that's important to consider. Now, hematocrit also plays a role with resistance. Remember, hematocrit refers to, the amount of formed elements you have in your blood. Now, these formed elements like red blood cells, white blood cells, and platelets, these have a tendency to make your blood more sticky and more viscous. So if viscosity is a resistance to flow, if you have more hematocrit, your blood is more viscous and therefore more resistant. And that means that flow is going to be a little slower, and your blood pressure might actually also be higher due to the fact that it's more resistant. So what we find then is, if you look at the structure of the heart, we'll see that the heart actually has several layers here. And the thickest of those is the myocardium here. Myocardium is made of basically cardiac muscle. Cardiac muscle is a type of muscle that these cells are very short. They're highly branched because they're interconnected by gap junctions. These cells are going to be under autonomic control, so involuntary control. And there's also regions of the heart that can generate their own action potentials, which means your heart can function and beat independently of the nervous system. Now, it's still under nervous system control and under the control of certain hormones, but it can still function independently of hormones and outside nerves to stimulate it. So that's the myocardium here. So if you have myocarditis, that would be inflammation of this particular layer. Now, inside of the heart, we have endocardium. Now, endocardium is actually made of a simple squamous epithelium. So it's a one-cell layer of flattened cells. And what we find then is that this is the same type of epithelium that also lines the inside of your blood vessels. So as blood vessels enter the heart, there's a continuous sort of epithelium that doesn't change from the vessel to the inside of the heart. And that's important because you want to avoid turbulence. We'll learn later how turbulent blood flow leads to blood clots. So you wouldn't want a whole lot of turbulence going on in your heart because that can lead to the formation of clots that can cause problems downstream. But that's called endocardium. Now, endocardium also surrounds your heart valves. Like this valve here is the right atrioventricular valve, also called the tricuspid. And this valve over here is called the left atrioventricular valve, also called the bicuspid or mitral valve. It's called a mitral valve because it kind of looks like a mitre hat, which is like the hat that the Pope wears. But these are the valves that separate your atria and ventricles, and they're also surrounded by endocardium. So endocarditis, which is inflammation of the endocardium, can actually not only damage the lining of your inside of your chambers of your heart, but can also damage your heart valves. And we'll learn later about how certain infections and drugs and inflammation can lead to damage to the endocardium and the heart valves in particular. Now, outside of the heart, we actually find a pericardium. Now, because the heart is beating so much and it's moving around a lot in your mediastinal cavity, we're going to need a lubricating tissue around the heart. So what we'll find then is that the heart is surrounded by a serous membrane, and we call this serous pericardium. So you have a visceral layer of serous pericardium, which is called epicardium, and a parietal layer of serous pericardium, which is on the outside here. And what separates those two layers is a fluid-filled cavity, which we call the pericardial cavity. That's actually full of serous fluid, which is a lubricating fluid. So as the heart muscle contracts and it starts to move, it's not rubbing up against nearby tissues because it's actually moving within a fluid-filled chamber. Now, that's serous membrane, and so that's serous pericardium. We also have a fibrous pericardium. So surrounding the whole heart, pretty much up towards the aorta, what we'll find then is this fibrous pericardium, which is a really thick, tough outer layer of the heart. And what the fibrous pericardium does is actually prevents overfilling of the heart. So that way the heart can't overfill too much and potentially tear itself. So the heart can only expand within the space that is sort of deep to this fibrous pericardium. Once the heart kind of fills up towards the fibrous pericardium, it can't expand any farther. And that can be good and bad. It's good in terms of overfilling, but it's bad if you have inflammation within the heart because then your heart is too constricted. And we'll talk about conditions like cardiac tamponade where you have sort of swelling that limits heart movement because it's all trapped within this fibrous pericardium. And this fibrous pericardium is really tough. It's a dense, irregular connective tissue, lots of collagen fibers, and it's really, really strong. Now, just kind of summarizing circulation and flow throughout the heart, we want to look at the chambers first. So we know that there are two superior atria and two inferior ventricles. Now, we have a right and left atrium, and as well as a right and a left ventricle. Now, remember from a previous slide, we said that the right side of the heart receives blood from your systemic veins, as well as your coronary veins, which actually enter through the coronary sinus back here. Now, the superior vena cava is going to drain blood away from your head, neck, and upper appendages, and the inferior vena cava is going to drain all the blood that is coming from structures that are inferior to your respiratory diaphragm. So we're saying the abdominal organs as well as your lower appendages. And so blood from these body regions then drains into right atrium. When the right atrium contracts, it's going to force a little bit of that blood, like the remaining 20% of it, in the right ventricle here, but most of the blood that enters the right ventricle actually just flows in through just pressure and gravity. And so 80% of the blood that fills your right ventricle is actually passive, and only 20%, which is active, is due to the contraction of your right atrium into the right ventricle. Now, when the right ventricle contracts, it's going to force blood up through the pulmonary trunk, and then the pulmonary trunk is going to divide immediately into left and right pulmonary arteries, which go to each lung, respectively. Now, when the right ventricle contracts, what prevents backflow of blood is this right atrioventricular valve, also called the tricuspid valve. Because if you look at this, you can see it has three cusps. You have 1, 2, 3 cusps here. And what happens then is that when the right ventricle contracts, blood forces up on these valve leaflets. The valve leaflets kind of snap shut, and then right around the same time, these papillary muscles contract. They're going to pull on these structures called chordae tendineae, which keep this valve closed. That way, blood can't flow back into the atrium and rather continues out through the pulmonary trunk. Now, there's another valve over here called the pulmonic valve, or the pulmonary semilunar valve. Now, this valve also prevents backflow of blood, but it prevents backflow of blood after the right ventricle contracts and that blood's forced up. Once the right ventricle starts to relax and pressure starts to fall in here, blood might have a tendency to want to flow back down from high to low pressure once the right ventricle starts to relax, but the pulmonary semilunar valve actually prevents that backflow and it snaps shut. Now, when these semilunar valves close, that's what's actually going to cause S2, which is the dub sound in lub-dub, when you have your heart contracting. Now that blood's going to continue out through the pulmonary arteries, out towards the lungs, and it's going to come back to the heart through the pulmonary veins in its oxygenated state. Now that blood's going to fill the right atrium and then enter the left atrium, and then enter the left ventricle here. And the same thing occurs on the left side as the right. So when the left ventricle contracts, the left AV valve is going to close, and then blood's going to get forced out through the aortic valve, through the aorta and beyond. Now if you look at the thickness of the walls here between the left and the right side, you'll see that the left side of the ventricle here actually has thicker musculature than the right side. And that actually makes sense because the right ventricle only has to pump blood to the lungs, which are pretty close. Whereas the left ventricle has to pump blood all the way out to the rest of your body, which could be as far as your tippy toes or like deep into your brain. So it has to generate a lot more force to get that blood to move. So we say that the muscle is actually thicker on the left side of the heart. Now, later on, we'll talk about the cardiac cycle, which are all of the events that occur when in a particular heart contraction. But just to summarize blood flow, we talked about how blood leaves the heart through the aorta. Now, some of that blood actually can nourish the heart itself because there's branches of the aorta, which we call the coronary arteries, like you have the right and left coronary arteries, that supply blood to the heart itself. But the rest of that blood is actually going to continue out through the aorta. We're going to leave the aorta either through the brachiocephalic trunk, the left common carotid or left subclavian, or it can continue down the aorta and then supply kind of inferior structures like abdominal organs and lower appendages. Now, in terms of coordination of heart muscle events, it's all about electrical activities. And so we're talking about action potentials here. Now, what's fascinating about the heart is, yes, it can generate action potentials on its own, independent of your nervous system, although it's still under nervous system control, and it's coordinated in such a way that your entire heart doesn't beat at once. In fact, your atria beat at the same time first, then there's a short delay, then the ventricles beat at the same time second. So what we're saying here then is that the top part of the heart contracts first, followed by the bottom part of the heart. And that makes sense because the atria need to force blood into the ventricles, and then there needs to be a delay for the ventricles to fill. Then the ventricles can contract and then force that blood out towards the lungs or out towards the rest of your body, respectively, whether it's the right or left side. Now, it all begins at the SA node. The SA node stands for sinoatrial node, and this is a little local area of a special type of cell, which is a conducting cell of your heart, and these are called pacemaker cells. Now, the SA node is located right at the juncture of your right atrium and the superior vena cava. And what's really cool about the SA node is it actually generates its own action potentials at about 100 times per minute. Now, we call these action potentials pacemaker potentials. And you can see that the pacemaker potentials look differently than the cardiac action potentials, which are down here. Pacemaker potentials have just kind of a smooth rise. Then you have an action potential, and then repolarization, and eventually going to get another one here. Now, the way that these are generated is that we actually have these funny channels, or leakage channels, that allow for a little bit of sodium, potassium, and calcium to flow, where there's a general depolarization of the voltage towards threshold. Once threshold is achieved, you're going to get a cardiac pacemaker action potential here. And the pacemaker action potential is actually going to be a calcium influx followed by a potassium efflux. And this type of action potential is going to spread then across the atria, where it's going to excite cardiac muscle cells along the way. Now, the cardiac muscle cells generate their own other action potentials, but these are generated in response to the pacemaker action potentials that begin at the SA node. Now, the cardiac action potentials are similar to other skeletal muscle action potentials because you have a sodium influx followed by a calcium plateau and then a potassium efflux, and it makes this kind of plateau-shaped type of action potential. Now, these action potentials are a little longer than skeletal muscle, and they also have this extra calcium plateau in the middle. So you have sodium influx through voltage-gated sodium channels, followed by a calcium plateau. So you have calcium influx through voltage-gated calcium channels, and then a potassium efflux, which causes repolarization of the voltage back down towards rest. Now, these action potentials spread from your SA node through the internodal pathways to the AV node. The AV node is another area of pacemaker cells. However, these pacemaker cells generate action potentials at 60 times per minute, whereas the SA node generates them at 100 times per minute. So we're saying that the SA node actually sets the pace because it's the fastest. So it's going to force the rest of these cells to beat at or make action potentials at the rate that it does. Now the AV node eventually can make action potentials and then send those along the bundle of His. Now what's important to note about this bundle of His is that it is actually a electrical bottleneck. So because of a narrowing of tissue here, we see that action potentials are kind of slowed here at the bundle of His. And that makes sense because you're going to need time for action potentials to spread from the SA to the AV node, for these cardiac muscle cells to contract to fill the ventricles before these action potentials start traveling down the ventricles and then exciting a ventricular muscle. So that makes sense, there's a delay here. However, the delay is 0.1 seconds, which is 100 milliseconds. So it's still, a pretty short delay. Now, from the bundle of His, we get the bundle branches. So you have the right and left bundle branches. Now the right bundle branch goes to the right ventricular myocardium, left bundle branch goes to the left ventricular myocardium. What's also important to note is that the bundle branches do not excite cardiac muscle here. Rather, you don't start exciting cardiac muscle till you get to the Purkinje fibers, which are out here, these smaller little branches, which we call the subendocardial conducting network. This is where you start to contract or start to stimulate, rather, the ventricular myocardium down here. It actually starts at the apex and works its way up towards the lateral parts of the heart. And that makes sense because you want the apex to contract first to force this blood up and out of the ventricle rather than down towards the apex. So the apex contracts first, and then you're going to force that blood out through their associated vessels. So if we look at the cardiac action potential, remember we have our ventricular myocardium action potential here, and these are the ones that are made by the cardiomyocytes, like the ones that actually produced muscle contractions. Now, these ones over here show the pacemaker potential, which looks differently, right? So what's interesting about this then is that with the myocardium action potential, stage 4 here represents rest. And if you look here, we see that resting voltage in a cardiac muscle cell is actually pretty stable. Like it's not changing, and it hovers just around negative 80 millivolts or so. Now, upon stimulation, what we find is then is a rapid rise in voltage to threshold. And then at threshold, you get the opening of voltage-gated sodium channels that allow for a sodium influx. Now, if positively charged sodium is flowing into the muscle cell, that makes the voltage more positive. And then near this peak over here, you get the opening of voltage-gated calcium channels. Now, those voltage-gated calcium channels allow for an influx of calcium, which then causes this plateau. And near this time as well, you get the opening of voltage-gated potassium channels. But because potassium is positively charged and it actually leaves the cell down its electrochemical gradient, we find then that potassium has a tendency to repolarize the voltage back down towards rest. But the reason why it doesn't repolarize right away is that you get this calcium plateau due to the voltage-gated calcium channels allowing for calcium influx. Now this is significant because calcium plays a role in muscle contraction. If y'all remember going back to skeletal muscle, we talked about how calcium can bind with troponin to help move tropomyosin from the thin filament. That way that your myosin heads can bind to the thin filament and initiate a power stroke to cause tension in your muscle. So calcium is really the key step here in the cardiac action potential. Now, this is the one that occurs in cardiac muscle cells. However, this one down here is the one that occurs in the pacemaker cells. Pacemaker cells are the ones that make up your SA node, your internodal pathways, your AV node, and your bundle branches and Purkinje fibers. Like those are going to be all pacemaker cells. Now, what's interesting about these pacemaker cells is that their action potentials are spontaneous, which means they can happen on their own. And what makes them spontaneous is the fact that their resting voltage is never really at rest. In fact, if you look at the resting voltage, there's a tendency for it to slowly depolarize up towards threshold. Now, the reason why you get this slow depolarization is because of these leakage channels. We call them funny channels because they allow for a little bit of sodium, potassium, and calcium to leak through the cell, but because it has a tendency to let more sodium and calcium in than potassium leaving, there's a tendency then for the voltage to become more positive over time. Now, once you've achieved threshold here, this is when voltage-gated calcium channels open. You get the rising phase of the action potential, then voltage-gated potassium channels open, and you get the falling phase of the action potential, and the whole thing can start over again. Now, this is one pacemaker action potential, and your SA node can generate 100 of these per minute. Your AV node can generate about 60 of these per minute, and your Purkinje fibers generate them at about 30 or so times per minute. But because the SA node generates them the quickest, it's going to set the pace for the rest of your heart, because it's going to kind of force the rest of the cells to generate action potentials at that pace. So what this question here says, how would each of the following affect heart contraction? Like if you gave someone a calcium channel blocker, how would that affect heart contraction? Or if you gave someone a sodium channel blocker, how would that affect heart contraction? Or a drug that opens sodium channels or a drug that opened potassium channels? Well, let's think about this, the role of these ions in action potentials. We learned earlier that voltage-gated calcium channels were a key step with the cardiac action potential, and calcium was a very integral atom for muscle contraction. So if you think about, well, what would a calcium channel blocker do to the heart? Well, it would actually prevent cardiac action potentials from occurring, and it would limit how strongly your heart's able to contract, because you wouldn't be able to let in as much calcium, and so you get weaker muscle contractions as a result. Now, similar effect with the sodium channels here too, because we learned how in the cardiac muscle action potential, how the first step was the voltage-gated sodium channels need to open. So if you gave someone a sodium channel blocker, then they'd have more difficulty even generating cardiac action potentials. And that would be opposite of this too. If you gave someone a drug that opens sodium channels, then they'd be more likely to depolarize more quickly and actually generate action potentials even more quickly. Or if you gave someone a drug that opened potassium channels, this would actually have a tendency to repolarize the heart and even hyperpolarize the voltage. And so this would actually have a tendency to inhibit action potentials. So you just got to think about what these ions are doing with respect to action potentials, and you know exactly how it's going to affect the heart. So this next question here says, which channels allow cardiac muscle to fire without a stimulus? Is it sodium, potassium, calcium, or chloride? Well, this would relate to the pacemaker action potentials, right? Because we're talking about how firing without a stimulus is pacemaker potential. And we said that pacemaker potential was due to calcium, sodium, and potassium. So you just got to pick an atom here, and this one they're saying is calcium. So we said that in the SA node and the AV node, the resting cardiac muscle cells have open calcium channels. And this is true in the sarcoplasmic reticulum as in the funny channels. So there's some calcium leakage into the cell, which causes the cell to depolarize or become more positive. However, sodium and potassium are also leaky. Now, I think the reason why we chose calcium here is that it's a doubly covalent, it's a double cation here. So this double cation means it's going to have a really strong effect on voltage because you're bringing in two positive charges instead of just one with sodium. So it's going to have an even stronger effect on voltage than like sodium or potassium. Now, if we look at the effective action potentials in the heart over time, we're looking at the ECG or electrocardiogram. So what's really cool about these ECGs is you're actually measuring all of the action potentials in a heart over time. And this is actually measured across the skin of your body, right? Like you can measure these changes in the electromagnetic fields across your skin due to heart muscle activities. And so we find here then is these large waves don't represent one action potential. Like these large waves here represent all of the action potentials in your heart at any moment in time. So the first wave here we have is called the P wave. Now the P wave correlates with depolarization of the atria. So if we're saying that the atria are depolarizing, that means that action potentials are beginning to spread across the atria during the P wave. But then we get a delay here in this PQ interval. In the PQ interval, the reason why we have a delay is because of the bundle of His, right? The bundle of His allowed for a delay between atria action potentials and ventricular action potentials. In fact, this next large wave, called the QRS wave, actually represents all of the action potentials that are occurring while the ventricles are depolarizing. So now we're saying that the action potentials are now spreading across the ventricles. Now we talked about why there was a delay here between the P wave and the QRS wave earlier, or why there's a delay between your atria and ventricle action potentials. Now, right around the time of this P wave, when the action potentials are beginning to spread across the atria are also starting to contract. And you need a delay for the ventricles to fill with blood before the ventricles generate action potentials, and then they start to contract. So you need a delay for the ventricles to fill. Now, the reason why your QRS wave is actually taller here than your P wave is you just have a lot more ventricular muscle than atrial muscle. Also, in the QRS wave, you actually would find repolarization of the atria, where action potentials are starting to go away in the atria, or they're repolarizing back towards rest. Then we get the QRS wave, and then there's a delay here, like this ST segment, and then the T wave correlates with repolarization of the ventricles. So now we're saying that the T wave represents when the ventricles start to go away or disappear, right, or repolarize back down to rest. Now, in certain conditions, you can get a U wave, and this would be common like in children and certain ionic imbalances as well, but you can get this next little wave here called a U wave. It's not always pathogenic. It can be a normal thing. Now, with the cardiac cycle, we're talking about all of the events that occur in the heart between a heartbeat, right? So cardiac cycle will be everything that happens in the heart in between one heartbeat, where it goes lub-dub, lub-dub, right? Everything that happened there between one heartbeat, cardiac cycle. Now there's two phases of the cardiac cycle. We got systole and diastole. Systole refers to ventricular contraction. Diastole refers to relaxation. Now, when the ventricles contract, blood pushes against the AV valves, which causes them to shut. Now, when these AV valves snap shut, they close with so much force that causes the first heart sound, which is lub. So when you hear lub, that occurs during ventricular systole when the AV valves snap shut. Now, if there's a problem with the AV valves and you don't get a nice lub sound, instead if it goes like lub, 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 then we know then that the AV valves might be damaged because that sound is due to the closure of the AV valves. Now, blood instead doesn't flow to the atria because those AV valves shut. Rather, blood flows through the semilunar valves, like the pulmonary semilunar and the aortic semilunar valves, up through the aorta and pulmonary trunk, respectively. Now, that continues for some time until you reach diastole. Now, remember, diastole is going to correlate with the T wave, which is ventricular repolarization or relaxation. And diastole is a state of relaxation. Now, as the ventricles relax, what we find then is that blood has already started to fill the atria at this time. Now, when the ventricles relax, there's a decrease in pressure in the ventricles, so that blood in the aorta and pulmonary trunk wants to flow back into the ventricles. However, the semilunar valves close here. So the semilunar valves close when the ventricles relax. That causes the second heart sound, which is the dub sound. So when it goes lub-dub, lub-dub, lub-dub. Lub is the closure of the AV valves during ventricular systole. Dub is the closure of the semilunar valves during ventricular diastole because it prevents backflow back into the ventricles. Now, shortly after, what happens then is that when pressure gets low enough in the ventricles, the AV valves will open up again, and then blood can flow back in the ventricles. But this is passive flow, and then sometime later, the atria will contract and force that remaining 20% of blood in the ventricles just before ventricular systole again. So this question here says, which of the following statements is correct about ventricular systole? Are the atria contracting during this time? Are the ventricles contracting here? Are the AV valves open? Or are the semilunar valves closed? Like, which of these is the most correct answer during ventricular systole? And it actually is ventricular contraction, right? Like, literally, ventricular systole means ventricular contraction. Now, we know that while the ventricles are contracting, the AV valves have closed. And that's why we get the lub sound in lub-dub. We also find, too, that early on in ventricular systole, the semilunar valves are also closed because the ventricles haven't generated enough pressure to open those semilunar valves. The semilunar valves will open later in ventricular systole, and that's what allows for ejection of blood from the ventricles out through your large vessels. So if we can talk about blood flow through the heart, we want to arrange these in their right order, right? So we got to pick a starting point here and then put them in the right order. So let's think about what's going on here. Which would occur first? Well, because it occurs in a cycle, you just got to pick a starting point. So let's say that, let's start with systole. So if systole is ventricular contraction, what that's going to correlate with then is the closure of the AV valves and then your first heart sound. Now that's going to continue, and as blood starts to leave through the large vessels, the semilunar valves open, and then as the ventricles enter diastole and start to relax, the semilunar valves close, which then causes your second heart sound, which is dub, and that occurs during diastole. And then what happens too, then again, is the AV valves will open up again once pressure in the ventricles gets low enough, and then we're back to start. So you want to be able to put these in the correct order, and these are phases of the cardiac cycle. Now, just some different equations we want to know to help us figure out things like blood pressure and blood flow. This first one we have here is called cardiac output, and cardiac output is CO. And cardiac output, the equation for this is stroke volume times heart rate. Now, cardiac output basically is just the amount of blood that your heart pumps out in 1 minute, right? Now, to figure out how much blood your heart pumps out in a minute, all you need then is heart rate and stroke volume, right? Heart rate is beats per minute. Stroke volume is blood per beat. So if you know then that cardiac output is equal to bloods per beat times beats per minute, what happened then is, you guys, is that beats cancel out, then you get blood per minute. So cardiac output is the amount of blood your heart pumps out in each minute. And you can rearrange this equation with other equations to get things like cardiac output is equal to stroke volume times your peripheral resistance, right? Like if you increase peripheral resistance, you're going to get a decrease in cardiac output. Or if you increase stroke volume, you're going to get an increase in cardiac output. Now this is important to note because you need enough cardiac output to supply your body's tissues with enough blood to meet their metabolic needs. Now, heart failure is the point at which your heart can't generate enough cardiac output to meet your body's metabolic needs. And we'll come back to that in future chapters. So keep this equation in mind because it's going to help us later. So blood pressure, we can actually determine as cardiac output times peripheral resistance. So we know that cardiac output is the amount of blood your heart pumps out in a minute, but peripheral resistance is actually caused by vessel diameter, vessel length, and viscosity. So the question here then we want to determine then is, well, what could increase peripheral resistance to increase blood pressure? Well, we talked about that increasing resistance could be caused by vasoconstriction, or a decrease in the diameter of your vessel. Increased resistance can also be due to a longer vessel or an increase in hematocrit, which makes your blood more viscous and more sticky, right, or more resistant to flow. So if you can increase resistance through vasoconstriction, that can increase blood pressure. Or if you increase cardiac output by increasing heart rate or stroke volume, that can also increase blood pressure. So something that's also important to keep in mind with respect to blood pressure regulation and blood flow. So we also learned in previous chapters how there's a lymphatic system that picks up excess fluid from our tissues. Now this plays a very intimate role with the rest of our cardiovascular system because blood pressure is proportional to blood volume. So if you lost too much plasma or water from your blood into your body's tissues, your blood pressure would fall out, right? So what we need then is a system then to bring excess fluid from our tissues back into lymphatic vessels, and those lymphatic vessels can bring that fluid back towards the bloodstream, kind of over by the jugular veins, to basically maintain normal blood volume. Because there's a tendency, though, because of bulk flow, for fluid to get forced from capillaries into tissues, but you need these lymphatic vessels to bring that fluid back to blood. Otherwise, your blood volume would decrease and your blood pressure would decrease. Now, we've already talked about, too, how your lymphatic system is involved with immune defense back in the previous chapter. So this discussion here says, how will each of these factors affect arterial size and peripheral resistance? So I'd like you guys to kind of comment in the comment area down below this video and tell me how lactic acid affects these arterial size or peripheral resistance, or how cold or endothelin or nitric oxide or low O2 or histamine or heat or adenosine, how do these affect arterial size and resistance, right? Well, these are going to change arterial diameter in some way, and that's going to have an effect on resistance. So if y'all remember, arterial size correlates with resistance, so that if the arterioles were wider, like if you have a larger diameter, that decreases resistance. And if your arterioles constrict and they get smaller, that's going to increase resistance. And so some of these are going to be vasoconstrictors and vasodilators. So I'd like you guys to comment in the comments down below and tell me which of these 8 here is a vasoconstrictor or a vasodilator. Now this next question here says, true or false, in patients with hypertension or high blood pressure, peripheral resistance is increased. Would that be true or false? Well, we got to consider our equation for blood pressure, right? So our equation for blood pressure is equal to cardiac output times peripheral resistance. So if blood pressure and resistance are proportional, that means if you increase resistance, you're going to increase blood pressure. So this is going to be true. So in hypertension, blood vessels can be constricted or narrowed, and smaller vessels have higher resistance, which makes it more difficult for blood to flow. So you have more resistance means more pressure.